This session, we will carry forward therapeutic guidelines from page number 113, oral mucosal diseases, and this is mucous membrane pemphigoid. Now, mucous membrane pemphigoid is an uncommon autoimmune vesiculobullous disorder. It is not very common, and it is autoimmune variant. Vesicles are formed, bullae are formed, which are the fluid-filled eruptions that affect stratified squamous epithelium. It occurs predominantly on the gingiva and palate, as we have seen here. And also in the case of Odell, it looks like, it mimics a lot like gingivitis. In this picture, though it is, one can think that this is a plaque-related or debris-related classic gingivitis. However, this is actually mucous membrane pemphigoid. It presents as a large, painful, persistent erosions and is characterized by subepithelial splitting with bulla or vesicle formation. So when you see the clinical appearance like this, you would have to ask the patient about how did this appear initially. The lesions heal with variable amounts of scarring, and differential diagnosis includes pemphigus vulgaris. Refer patients with suspected mucous membrane pemphigoid to appropriate specialists for biopsy and definitive diagnosis. Management usually requires long-term use of immunosuppressive therapy. Ophthalmologist review is necessary because there is risk of blindness with mucous membrane pemphigoid. So this is the ophthalmic consultation, as we read in Odell also. Referral to ophthalmologists is very important in these cases. Even in the even referral to medical practitioner would be key to passing the case if it comes any oral mucocutaneous lesions and it looks like somewhere mucous membrane pemphigoid. Then next we have oral candidiasis and candida associated lesions. Now, candida species are a commensal organism of the oral cavity. Oral candidiasis is an opportunistic infection that is uncommon in healthy individuals. It only affects immunocompromised patients. However, it occurs relatively commonly in neonates. Table 10 below lists common risk factors for oral candidiasis. And the next table we would go through gives an overview of clinical features, predisposing factors, and management of oral candidiasis and candida-associated lesions. So if any red flag features of oral mucosal disease are present, the preliminary red flag features we always have to remember, refer to an appropriate specialist. So what are the local factors for candidiasis? Dentures, salivary gland hypofunction. It is commonly seen in patients who have dry mouth. Corticosteroid inhalers, which compromise the immunity. Poor oral hygiene can lead to candidiasis, and smoking also aggravates candidiasis. Then we have smoking along with the other factors. Smoking exclusively would not predispose to candidiasis per se. With poor oral hygiene, with any immunocompromise happening with this, it can aggravate candidiasis. Then again, another risk factor, systemic wise, is immunocompromise. One is poorly controlled diabetes and drugs, systemic corticosteroids or antibiotics, which reduce the immunity. These are the commonest risk factors for candidiasis. For the management of oral candidiasis in patients receiving palliative care, see management of the specific oral problems in the palliative care. So basically, we have to treat the underlying condition to treat the oral candidiasis. The rest, everything is the palliative care for controlling the infection. And in the cases of oral candidiasis management in immunocompromised patients, it requires specialist advice. And patients with undiagnosed HIV infection may present initially with oral candidiasis. For patients with HIV, say oropharyngeal candidiasis in adults with HIV infection. What are the clinical features for candidiasis? First, the most commonest type of candidiasis is pseudomembranous type. Here, creamy white curd papules or plaques that are sometimes removable. So this can be scraped off with a probe or any instrument, and they leave a raw red, often a bleeding base when we try to remove them. They are generally asymptomatic, may affect oropharynx if it is behind the last part of the palate, and soft palate area may get involved. If the dorsal tongue is affected, auto-inoculation of the palate may occur. So from tongue to palate. Then predisposing factors, what we have discussed here: poor immunity, diabetes, dentures, salivary gland hypofunction, all these. Then what is the management? Manage first the underlying condition, manage the predisposing factors. If you treat the underlying condition, that is the cure for candidiasis. And then to suppress the fungus, we would do topical antifungal therapy for oral candidiasis. If the infection affects oropharynx, we have to refer to specialists for the management. So first one was pseudomembranous candidiasis. The second type is erythematous candidiasis. It has sensitive red lesions, as the name itself says, commonly affecting the palate and the tongue. The tongue may appear depapillated and smooth. Predisposing factors are, like we have discussed before, and broad-spectrum antibiotic therapy can also lead to erythematous candidiasis. Management is address the predisposing factors, use topical antifungal therapy for oral candidiasis. Then we have hyperplastic candidiasis. This was pseudomembranous candidiasis. This is hyperplastic, which becomes like asymptomatic, non-removable white plaques. So they were scrapable in pseudomembranous. In hyperplastic, the tissue is becoming hyperplastic, means it is going layer by layer, topping up. So it forms non-removable white plaques that may appear nodular. Usually affects the retrocommissures, anterior buccal mucosa, and the lateral tongue. It may be bilateral. The hyperplastic candidiasis may resemble oral leukoplakia. So see the differential diagnosis of oral leukoplakia and candidiasis so resembling here, because both are somewhere hyperkeratinization. This somewhere is hyperplastic tissue which forms nodules, and oral leukoplakia is keratin is heightened. Okay. Predisposing factors remains the same, and then management also similar. Now this one may be associated with epithelial dysplasia. So it is the one which is highly mimicking our leukoplakia, because that also, if epithelium becomes dysplastic, it can lead to carcinoma in situ, and it is a pre-malignant lesion. Likewise, this may be associated with epithelial dysplasia, and we must refer to specialists for biopsy and management if candidiasis is of hyperplastic degree, nature. Then we have angular cheilitis or angular stomatitis. Now, this is painful erythema and fissuring of the corners of the mouth. It is usually caused by mixed infection of Candida and Staph aureus and Streptococcus species. It is often associated with intraoral candidiasis. So, its predisposing factors, apart from what discussed below above, are deep skin folds around the mouth, associated with worn down teeth or ill-fitting dentures or not wearing dentures. So when a patient is not wearing dentures and there is overclosure of the mouth, this area keeps on, becoming moist, and there is inadequate oral hygiene maintenance. It leads to fungal growth, which is candidiasis in this region, that is angular cheilitis. Now, iron, folate, or vitamin B12 deficiency can also lead to this. Crohn's disease, granulomatous disease, and atopic or seborrheic dermatitis can also lead to angular cheilitis. Then, management of angular cheilitis actually is dental review to assess denture or dental related causes. Address the predisposing causes, whatever you find out, maybe it's Crohn's disease or it is ill-fitting dentures. So addressing the chief cause will remediate this again, like candidiasis, and use topical antifungal therapy for angular cheilitis. Treat oral candidiasis if present with topical and antifungal therapy for oral candidiasis. So we can't say that fungus created angular cheilitis. There was a ground developed for, or initial insult would have already started. Then this area was friable, frail, lacking that keratin, toughness, and fungus thrived in there. That's why it is not a predominantly fungal disease, but still Candida can thrive in such situation like moist corner of the lips, inadequate oral hygiene, denture-related patient not wearing dentures. So this is secondary kind of a Candida inhabitation. Next, we have denture-associated erythematous stomatitis. So one was erythematous candidiasis by itself. Other is denture-associated. Here, the cause is defined. The chief etiology is defined. It is sensitive erythematous lesions confined to the denture-bearing areas, particularly the palate. It may appear punctate or smooth and red. Nodular hyperplasia may be observed. Predisposing factors we would see like seen before. Ill-fitting dentures, suboptimal oral and denture hygiene, and dietary factors. Then we have management advise patient to optimize denture hygiene and to remove dentures at night, clean them, and then store them dry overnight. Nowadays, it is not recommended to put dentures in the bowl of water and keep it overnight. It should be kept dry overnight to not let fungus thrive in the moistened surfaces. Dental review to assess fit of dentures. If symptoms do not resolve after 1 month of optimal oral and denture hygiene, use topical antifungal therapy. First, advice must be to remove denture and not wear it. Give a denture gap. Okay, wearing gap to the dentures. So even after meticulous oral hygiene and conditioning of the oral tissues using topical antifungals, it does not clear up in 1 month. Then it doesn't resolve after oral hygiene, use topical antifungal therapy for oral candidiasis applied inside the mouth and to the dentures. So once I was practicing in another incident I'm sharing, a clinical case. I had a patient in a rural setup. Just after my internship, I was practicing for a year, for a month and a half in a rural setup. So there visits a villager lady back in India. And I had not seen such a devastating candidiasis in anyone's mouth. I have still the memory of that patient. She got this denture made from these denture technicians and somebody who's not a dentist. They just, these are not customized dentures also. These are stock dentures which are sold and somehow they fit into the patient. They just alter it and fit it in the patient's mouth. So her dentures were fitted with this orthodontic, wires and tied to the remaining teeth. She had not removed those dentures for maybe, I don't know, since she has got them in. So 3, 4, 5 years, 6 years, 7 years, I don't remember that part. But also the plaque buildup and the tissue surrounding was actually, what is the word to use? Putrefaction is one thing, but as if, means if not, if it was still late for her, and even that was a very primary care center, I was just there for a minimal period. So with lot of difficulty with, these orthodontic equipments, I loosened the wire with the help of another assistant I had. So we too had to actually, it was much difficult than doing any third molar extraction, removing that denture, because it was tied nicely to the remaining teeth. And after that remaining tissue and her gum region was actually hollowed out. It was looking like the picture we see in the cigarette packs where the tissue is gone. So it was such a heavy denture associated candidiasis. And maybe if biopsy is done, she would have had dysplastic lesions or something. So that is the level of negligence and oral health inadequacy in many of the rural and disadvantaged population go through. So she was given a denture. She thought it is a permanent thing to keep in. And it was a horrific sight. It was smelling like, imagine some pipeline not being cleaned for however period. So yes, this was one personal case, which the most horrific case I had seen till now. Then comes, okay, moving on to the next, this one, median rhomboid glossitis. Clinical features of this lesion are, it is median, centrally placed, rhomboidal in nature, rhomboid area of depapillation and erythema in the midline of the dorsal tongue, maybe fissured or nodular. Auto-inoculation of the palate may occur, usually asymptomatic, although it may sting or burn. And then we have predisposing factors for this are risk factors for the oral candidiasis discussed above. Management: address the predisposing factors, use topical antifungal therapy. Now, everywhere they have written use topical antifungal therapy, okay, and treat the predisposing factors. So what is the topical antifungal therapy prescribed by them? So for management of oral candidiasis in patients with HIV infection, we would see oropharyngeal candidiasis in adults with HIV infection in other TG. For management of oral candidiasis in patients receiving palliative care, we would see it separately. In immunocompromised patients, it requires specialist advice. Now, antifungal therapy is not always necessary for oral candidiasis and candida-associated lesions. For indications of these, we would see the table ahead. Now, successful treatment relies on adequate contact time between antifungal and the affected mucosa, so advise patients not to eat or drink directly after administration. Treat oral candidiasis in neonates and children younger than 2 years with topical antifungal. So, in neonates and children younger than 2 years, topical antifungal would be needed. In infants, apply the dose in front of the mouth to avoid choking. So what is the dose? Nystatin, 1 million units per ml. Suspension or 1 ml, this per ml suspension, 1 ml in quantity, apply topically, then swallowed. 4 times daily after feeding for 7 to 14 days. So after feeding, because it is to retain on the affected area for a continuous contact. Continue treatment for 2 to 3 days after symptoms resolve. So it is 7 to 14 days after feeding 4 times, 1 million units per ml suspension and 1 ml. And after the symptoms resolve, it has to be continued for 2 to 3 days more. Or we can use miconazole gel, which is 2% gel, 1.25 ml topically, then swallowed. 4 times daily after feeding for 7 to 14 days. Continue treatment for at least 7 days after symptoms resolve. Then we have treat oral candidiasis in adults and children 2 years and older with miconazole 2% gel, 2.5 ml topically, then swallowed 4 times daily after food for 7 to 14 days. Continue treatment for at least 7 days after symptoms resolve. So this is adults above 2 years or older. 2% gel, same remains. Here it was 1.25 ml. It is double here, 2.5 ml. Again, the timing is same. 4 times daily after food, 7 to 14 days. Amphotericin B, 10 milligram lozenge in adults. There it was nystatin, here amphotericin B. Nystatin will also come, but the second option here, they have made amphotericin B. Lozenge sucked, then swallowed 4 times daily after food, 7 to 14 days. For continue it, so 2 to 3 days after symptom resolve. Here it was 7 days. Nystatin, same, 1 million units, right? Yes. Per ml, suspension 1 ml topically, same. It is the same as was in the less than 2 years old. Exactly the same prescription as was given for them. Advise patients with dentures, and they have clearly mentioned that nystatin suspension contains sucrose. So one has to be mindful for using them in patients who are diabetic or neonates because it contains sucrose. Advise patients with denture to use miconazole or nystatin because the antifungal should be applied to the fitting surface of the dentures at least twice a day. So lozenge would not be helpful in the dentures. Only miconazole or nystatin would work. And dentures should be removed from the mouth at night, then cleaned and stored in a dry environment overnight. And we would read cleaning and denture instructions later. Evaluate patients with intractable candidiasis for systemic disease, like diabetes or HIV infection. If doesn't respond to oral hygiene after doing the thorough cleaning, removal of the dentures, following through that denture gap for 7-14 days, it should be followed in for referral to the specialists. Medical physician and maybe specialists for intractable candidiasis. Then we have antifungal therapy for angular cheilitis. This is the one which is corner of the mouth. So here it is a bit different. Miconazole remains the same, which is 2% cream. There it was gel when we were using intraorally. Outside at the corners, we can use cream, miconazole, same. Twice daily for at least 14 days. Continue treatment for 14 days after symptoms resolve. Or we can use clotrimazole 1% cream topically for the angles of the mouth twice daily for at least 14 days. Continue treatment for 14 days after symptoms resolve. A mild topical corticosteroid can be used in addition to the topical antifungal to treat the associated inflammatory dermatitis. Use hydrocortisone 1% cream topically to the angles of the mouth twice daily until inflammation subsides. Then we have combination products containing a topical corticosteroid and antifungal are available. So mixing of steroid and antifungal, but should only be used until inflammation subsides, because This candidiasis is because of immunosuppression. Topical corticosteroid would eventually, it's a more immunosuppressant. Okay. Treatment should be completed with topical antifungal alone for 14 days after symptom resolve. So we should be quitting from topical corticosteroid soonest. It is just hydrocortisone 1% cream topically to the angles of the mouth until inflammation subsides. Only till inflammation is subsiding, we are taking help from them. If oral candidiasis is present, treat with antifungal therapy. Seek specialist advice for persistent angular cheilitis. Treatment for mixed infection may be required, or it may be a symptom of a systemic condition such as Crohn's disease or granulomatous disease. So this completes our candidiasis. And next is oral mucositis. So oral mucositis is basically inflammation of the oral mucosa. Okay, as simple as that. In children, we will seek expert advice. Then we have managed oral mucositis in conjunction with a multidisciplinary team, which includes addressing the cause, why this mucositis is there, symptomatic relief, oral care regimens, and nutritional advice. So initial and regular ongoing assessment of oral pain is essential, because the full mouth will be inflamed. Patient would not be able to eat properly. There would be nutritional compromise, and the patient would be having a lot of pain. So lubricants and analgesic mouth solutions may reduce pain and inflammation. Artificial salivary products can be applied as necessary for transient relief of oral dryness. If a topical analgesic is needed, use benzidamine hydrochloride, 0.15% solution, 15 ml. This is anesthetic solution. Benzidamine is an analgesic solution. Okay, so benzidamine, 0.15%, 15 ml, rinsed in the mouth for 30 seconds, then spat out, 1.5 to 3 hourly as necessary. So it is a painkiller. So it depends upon how much of the pain relief patient wants. 1.5 to 3 hourly, it can be repeated, swishing in the mouth and spitting out. Use diluted with 15 ml of water if stinging occurs. If it is giving, a stinging sensation of a, burning sensation because mouth is inflamed already. Then we have lidocaine 2% viscous solution. As we know, this is the anesthetic. Use the lowest dose necessary. Up to 15 ml, rinsed in mouth for 30 seconds, then spat out. 3 hourly as necessary, maximum 8 doses in 24 hours. So if pain is not adequately managed with topical measures, systemic analgesics may be required. And seek advice from the patient's multidisciplinary team. Establish preventive oral care regimens. Regularly assess the oral cavity. Patients with profound mucositis have difficulty performing oral hygiene measures effectively. So this should be encouraged nevertheless. So there would be difficulty in oral hygiene. The patient would be negligent about it because it is very painful. However, keeping the mouth unclean, again, super added infection can occur, candidiasis can occur. Chlorhexidine limits exposure to waterborne pathogens and can be used when pain and discomfort restrict oral hygiene practices. Use chlorhexidine 0.2% mouthwash, alcohol-free, for keeping the mouth at least clear of pathogens. So chlorhexidine 0.2%, 10 ml, rinsed in mouth for 1 minute, spat out 8 to 12 hourly. Again, if dilution is needed because stinging is occurring, we can dilute chlorhexidine 0.2% also with 10 ml of water. Chlorhexidine gel is an alternative oral hygiene adjunct to mouthwash and may provide some lubrication and ease discomfort. So use chlorhexidine 0.5% gel, alcohol-free, apply 2 to 3 times daily to all mucosal surfaces and gingival margins. Nutritional support for patients with mucositis is important. So we are taking care of oral hygiene, we are taking care of the pain, we are taking care of nutritional support. Encourage patients to avoid irritant foods, example, acidic, spicy, salty, dry, or abrasive foods. So very high important recommendation to ask patients to avoid these foodstuffs. Refer patients for specialist nutritionist advice if mucositis is severe. So you have to refer for the nutrition advice to the specialists. This completes the oral mucositis part, and then begins the dry mouth. We would start the dry mouth in the next session. If you have any doubts.
Ma'am, for the dentures, just now you mentioned that now we don't advise patients to keep it in the water.
Yes, overnight.
But I thought then we'll have shrinkage, right?
Overnight?
If we don't store.
No.
Yeah.
Overnight it won't shrink, and once your acrylic is cured properly, it won't shrink. If patient is not wearing for say a long period, 14 days, 20 days, 1 month of gap is there, then it shrinks.
Oh, okay.
But since long, these guidelines have like prosthodontic guidelines have changed, and patients are advised to nicely wash it, dry it with a clean cloth, and keep it dry in the mouth. Overnight, keeping in water creates a kind of a slimy layer, and yeah, it is more predisposing to that, what do we say,
Candidiasis. Yeah.
candidiasis is a later on thing, but at least that first layer of slime which is produced in the microorganisms can grow on that wet surfaces.
Okay. Okay, ma'am.
And if the denture is cured nicely, nothing will happen. Overnight, it won't, and the patient is wearing the dentures daily. Actual advice is to wear from morning till night, wash it, clean it, maintain the regular oral and denture hygiene, and keep it dry.
Okay. And oral mucositis is not the same as burning mouth syndrome, right?
Oral mucositis and burning mouth syndrome. Let me check. It looks so familiar, but burning mouth syndrome. No. Burning mouth syndrome is actually when we see burning mouth syndrome, it's a chronic and intractable orofacial pain syndrome characterized by presence of burning sensation of the oral mucosa in the absence of specific oral lesion. So it is actually, a patient also complains of oral mucosal pain, altered taste sensation, and dry mouth. But it's more of a burning sensation and not a painful situation, which is oral mucositis. Mucositis is inflammation. Here, absence of specific oral lesion. So there is a difference.
Okay.
Very good
Okay,
question.
ma'am.
Yeah. Because it can be taken as a similar.
Yeah, because they have a lot of similar clinical features actually.
Yes, yes.